Welcome. In this advanced explainer, we're going to deconstruct the systematic method you absolutely need for interpreting those really complex ECGs. We're going to focus on the fine-tuned diagnosis of cardiac hypertrophy and the whole spectrum of conduction system blocks. We're talking everything from simple bundle branch blocks all the way up to advanced multifascicular disease.
So here's our roadmap. We'll start by laying down a foundational systematic framework. Next up, we'll use the axis as our critical pivot point to explore what's happening on the left and right sides of the heart. From there, we'll follow those left and right-sided pathways, and to wrap it all up, we'll synthesize everything we've learned to interpret some really complex multifascicular conduction blocks.
All right, first things first. Before we can even think about making a diagnosis, our analysis has to be grounded in a consistent, repeatable framework. This methodical approach is an absolute prerequisite for getting to an accurate interpretation. You just can't skip it.
And here it is, the 6-point checklist that forms the bedrock of our entire analysis. Every single ECG interpretation has to start here, by methodically going through each of these elements one by one. This is how you make sure no critical finding gets overlooked before we dive into the more advanced pattern recognition.
You know what's really cool is how just a careful look at the P-wave morphology can give you your first big clue about atrial issues. If you see a tall, pointed P-wave, we call that P pulmonae, that's a hint towards right atrial enlargement. You see this a lot in things like COPD. On the other hand, if you see a bifid or notched P-wave, known as P mitrale, that's characteristic of left atrial enlargement.
So now that we've got the foundational stuff down, we've come to a critical juncture. Determining the heart's electrical axis isn't just another step in the process. It is the single most important pivot point that's going to direct the entire rest of our diagnostic pathway.
And that leads us to a really important question. After you've done that initial review, what's the one single finding that tells you where to go next to look for hypertrophy or a block? Well, the answer, without a doubt, is the axis.
This slide illustrates this central idea perfectly. Think of the axis as a diagnostic signpost. If you have a leftward axis deviation, it's telling you, hey, go investigate the left side of the heart. So you'll look for things like left ventricular hypertrophy or a left bundle branch block. And conversely, if you've got a rightward axis deviation, that's your signpost to check out the right side of the heart for its own set of problems.
All right, so let's follow that leftward path. When the axis points left, we now systematically hunt for evidence of left ventricular hypertrophy, or LVH, and the conduction issue that often goes with it, left bundle branch block, or LBB.
Okay, so the main tool we use to diagnose LVH on an ECG is the Sokolow line index. It's basically a set of voltage criteria that directly reflects the bigger electrical signal you get from an enlarged, thickened left ventricular muscle. More muscle means more voltage.
It's that simple.
So how do you nail down the diagnosis? Well, you're looking for one of two things. You can take the depth of the S wave in V1 or V2 and add it to the height of the R wave in V5 or V6. If that sum is more than 35 millimeters, you've got it. The other way is just to look at the R wave and lead AVL. If it's taller than 11 millimeters on its own, that's also enough to make the call.
Now, here's a really important challenge. You have to be able to tell the difference between the ST wave changes you see with LVH, we call that a strain pattern, and the changes you see with myocardial ischemia. The absolute key is the T-wave shape. The strain pattern gives you this characteristic asymmetrical T-wave inversion. Ischemia, on the other hand, typically gives you a symmetrical, kind of arrowhead-looking inversion. It's a subtle but crucial difference.
And we can get even more specific. It's really important to distinguish between two different types of LVH. First, there's concentric hypertrophy, which you get from pressure overload. Think hypertension or aortic stenosis. This usually shows you the whole package: left axis deviation, that strain pattern, and the voltage criteria. But then you have acentric hypertrophy from volume overload. With this type, you might only see the voltage criteria met while the axis is normal and there's no strain pattern.
Okay, let's pivot. If our initial axis check pointed to the right, we're now following that diagnostic trail. We're on the hunt for evidence of right ventricular hypertrophy, or RVH, and its partner in crime, right bundle branch block, or RBB.
The diagnosis of RVH really comes down to one key thing: a reversal of the normal R to S wave progression in the chest leads. Normally, the R wave gets taller as you go from V1 to V6, but in RVH, that pattern gets flipped, especially in lead V1. This flip is a direct result of the thickened right ventricular muscle changing the direction of the heart's electrical forces.
So, to be specific,
The hallmark sign of right ventricular hypertrophy is when the R wave in lead V1 is taller than the S wave. That gives you an R to S ratio greater than 1. This is a complete flip of the normal pattern, where the S wave is almost always bigger in V1.
This table is a great little cheat sheet for telling the bundle branch blocks apart. For a right bundle branch block, look at lead V1. You'll see that classic R-SR' pattern, which looks kind of like an M. Then, if you look over at V6 on the left, you'll see a wide, slurred S wave. For a left bundle branch block, it's the opposite. In V1, you get a deep, wide QS pattern that looks a bit like a W, and over in V6, you get a broad, notched M shape.
All right, now we're going to take it to the next level. Let's start integrating what we know about axis and QRS morphology to diagnose some of these more complex, multi-level conduction diseases.
The logic for diagnosing a bifascicular block is actually quite elegant. So first, you identify a clear right bundle branch block. Now, normally an RBB should give you a rightward axis. But what if you see a leftward axis instead? That's a paradox, and it tells you something else must be going on. It means that on top of the RBB, there also has to be a block in one of the left-sided fascicles.
So what is a bifascicular block? By definition, it just means there's disease in two of the heart's three main conduction pathways. This usually looks like an RBBB plus a block of either the left anterior or left posterior fascicle. And here's a critical point. An isolated left bundle branch block is also considered bifascicular because the left bundle itself has two fascicles.
And this brings us to the final level of integration. Let's say you've already identified a bifascicular block. If you also see a first-degree AV block, which you'll spot by a prolonged PR interval, you can then diagnose a trifascicular block. This is a big deal. It signifies pretty extensive disease affecting all three of those major conduction pathways.
This quote from the source material is just perfect, isn't it? It really highlights the gap between just memorizing facts to pass an exam and developing the deep, integrated understanding you need for real clinical mastery of ECGs.
Lastly, we have to talk about a critical clinical tool, Scarbosa's criteria. This is what you use to diagnose a heart attack when the classic signs are being hidden by a pre-existing left bundle branch block. It's all about looking at the ST segment changes compared to the QRS. If the ST segment moves in the same direction as the QRS, what we call concordant, that's a huge red flag for ischemia. Another sign is excessively discordant changes, where the ST elevation is way out of proportion to the S wave before it.
So as we've seen, an ECG isn't just a random collection of squiggles. It's a logical story about the heart's electrical function. And a systematic, axis-driven approach is the key that unlocks that story. It allows you to move step by step from the very basics all the way to a precise, and often, a life-saving diagnosis.